Yeah, we sometimes talk about the most exciting thing or the most flashy thing, but sometimes it's just the, regular day-to-day things which have the greatest impact. And I think that's true with all these immunotherapies, bispecifics, and CAR T cells. We talk about the CRS, we talk about the ICANS. Some of those things are very rare that they impact patients significantly. If someone has grade 1 CRS, it's of no impact. We all get grade 1 CRS when we get a flu vaccine. It's just a fever. It's not a big deal, but it gets a lot of attention. So, again, high-grade CRS, pretty rare with bispecifics, pretty rare with some of these more modern iterations of CAR T cells, but they still get a lot of attention. All right, deservedly so. We need to pay attention to them in the beginning. But really, the impactful thing for these patients, adverse effect-wise, is just the same old toxicity that every therapy we almost ever give is, which is increases in cytopenias a little bit and infections. And again, these don't happen just in the first few weeks when the CRS and ICANS could occur. This can happen in the first months or really even later on in the therapy. And again, because there are things we're familiar with, every chemotherapy we've ever given increases infection rates. So this is something we're familiar with. So maybe it's not as novel and exciting, but it is as or probably more important for these patients. And we always saw some infections. We see patients getting infections even when they're on no therapy at all. But we always saw some infections in these early phase trials of bispecifics as well as CAR T cells. But now that we have some more published randomized trials of, for example, bispecifics on top of standard of care therapy. So one example is second-line follicular lymphoma. We already had, we say, R-squared, rituximab plus lenalidomide. And now when we've added epcoritamab to that in this randomized trial that was now published last year and now is an FDA-approved second-line follicular lymphoma therapy, we see that the bump in infection rates is significant. I still think that therapy is probably the best therapy among standard options now for patients with relapsed FL, but we cannot ignore that increased infection rate. So instead of just worrying about it, there are some things we can do about it. We have to be pushing all of our patients to be getting their appropriate vaccinations, hopefully prior to therapy when possible. So, annual flu vaccines, their pneumonia vaccine, if they haven't had one in a reasonable window, RSV, shingles vaccines, all of these things to prevent infections. Even aside from the immunotherapies, the bispecifics, some of these supportive care we give, or even prophylactic care like steroids, dexamethasone, that increases infection rates in the beginning as well. So we have to be giving prophylactic antibiotics sometimes along with dexamethasone, like Bactrim, probably be giving acyclovir or valacyclovir for shingles prophylaxis for most patients, again, in the beginning of the therapy when the dexamethasone is on board. So infection rates are higher with bispecifics. These are moderate bumps, but they're significant and they impact the largest number of people in terms of total adverse effects. And they are something that we can do something to avoid, to minimize, to prevent, and then also to monitor closely for, because this, is going to be standard of care therapy for patients, even in the second line setting for lymphomas, but in the near future in the front line setting for lymphomas. So we have to be looking for these and taking care of these patients literally day by day because they need close attention.